All right, good evening, everybody. Thank you very much for tuning in. Welcome to the Ultimate Pulmonary Wellness webinar series. We are very honored tonight to have Dr. Howard Weintraub. Dr. Weintraub is a cardiologist. He's a clinical professor of medicine at New York University School of Medicine in New York City and the clinical director of the NYU Center for the Prevention of Cardiovascular Disease. Dr. Weintraub's principal research interests include the impact of risk factors such as hypertension and hyperlipidemia on endothelial function and the development of atherosclerosis. In his clinical practice, he specializes in the prevention of atherosclerosis, disorders of lipid metabolism, hypertension, carotid artery ultrasound, and exercise stress testing with echocardiographic imaging. Welcome to the show.
Hi, Noah. How are you?
I'm fine. I would like to say that I have known Dr. Weintraub for probably close to 20 years now, and he's, if not the smartest guy I know in any field, certainly one of them. I want to say before we go on, thank you to the American Lung Association for their sponsorship of our Better Breathers Club. I want to say hello to my Breathe Easy group and to everyone else on Facebook. And I want to give the usual disclaimer. What you're about to hear tonight are our opinions. Don't run right out and say we told you to do it. We're not. Anything you do, discuss with your physician first. And without further ado, let's get going. So, Dr. Weintraub, we want to talk tonight about, first of all, one of your biggest specialties, prevention of heart disease. So what do people know about how to not get it in the first place?
That's a good question. So first of all, you should know what you can modify and what you can't. There are things that are unambiguous, preventable risk factors. The ones that are not preventable are obvious: age, gender, and family history. It'd be nice to be able to pick your parents, but it's something we haven't perfected yet. I understand they're working on it in England, but we haven't done that yet. Okay. So aside from that, what I can tell you is that cardiovascular disease that most of your listeners are accustomed to, that of heart attacks and strokes, that is still the largest killer of anything else in this country, and is going to affect anywhere from 1 in 2 to 1 in 3 people in this country, is that heart attacks and strokes are thoroughly preventable. Now, sometimes it would imply doing something the right way from the time you were born. It's called primordial prevention. Most of us aren't that fortunate. You find out that there's a problem, maybe you're 30, maybe you're 40, but there is still the opportunity for primary prevention, which would mean that there may be some plaque sitting in your arteries, but you would still not have a stroke or a heart attack. And I think that this is a laudable thing to pursue. It involves looking at the modifiable risk factors and being as aggressive, focused, and precise as you possibly can be, as you want to be. I mean, I'm a quality of life guy. I'm not going to tell somebody that, listen, I want you to torture yourself just so you can live longer. Someone may say to me, what makes my world is a steak at Ruth Chris.
Creme brulee.
That's exactly
it. I'm not giving it
up.
What
it is. What it is. I tell them, you let me know what you're going to do, and then I'll do all the heavy lifting to get the other stuff done, or as much as I can. Clearly, they just need to be ready for me to use more medicines or to have a less than perfect outcome. But the good news is, with blood pressure controlled appropriately, with people not smoking, and no, I'm sure you know as well as anybody what happens when people smoke. We'll get into that a little bit more. Watching your cholesterol levels, and not just cholesterol, but all lipids, which means triglycerides, looking out for your HDL, LDL, etc. And then there are other more exotic numbers. Very, very importantly, watching the development of diabetes. And I don't need to tell you that this country is in the midst of a huge metamorphosis into being obese individuals. There is only 1 or 2 states where high numbers are not already obese. The number of diabetics in this country grows logarithmically, and the scariest part is emerging countries and those that were previously not afflicted, like the Pacific Rim, China, Japan, and then really in all of India, Southeast Asia, the rate of diabetes and hence heart disease is skyrocketing. The number of diabetics in the country is going to approach 500 million people in the next, right. So, and diabetes to me is like fertilizer for cardiovascular disease. And what I tell people about diabetes is that A, you never want to hear me say you have it. B, diabetes, if you look at diabetes, it's like a cardiovascular malignancy.
Okay.
It's meaning malignancy strikes terrible things in your brain. The news about malignancy, though, is if you have a cancer and you're alive 5 years later, you beat it. With diabetes, 5 years is just getting started.
Right.
By the time this takes hold, you'll be willing to make a deal with the devil, but there's no one to broker the deal. So as you've lost a couple of toes or had a stroke or a heart attack, a couple of stents are now living in your coronary arteries, you have blockages in your leg arteries, and of course probably to get there you were smoking, so you're huffing and puffing. At that point, your quality of life has gone to hell. There is very little you're going to be able to do to absolutely stop the progress. You can slow it, but you can't stop it. So there is extraordinary opportunity to be able to intervene earlier. But regrettably, there are still about 1 million heart attacks that happen every year. And we need to be attentive to these people. And my job is to make sure that no one ever has to go inside a cardiac catheterization laboratory. And that those people that have had the unique opportunity to be inside of one, either due to a heart attack or needing a stent, I try to do it that they never have to go back. And knock wood, this is not wood, we've been very successful in doing that. And I think this has been, we were talking just before about am I happy doing what I'm doing, and the gratification, some people get gratification putting a stent into someone's arteries. I get gratification when they don't
Keeping them out.
Exactly right.
Yeah.
And that's kind of how I feel.
I think for some reason diabetes is one of those things that people have sort of a vague idea of what it is. They think, oh, my sugar's a little high, but they don't realize just how many systems, I mean, every system is affected by it.
Exactly.
And I think they don't jump on it in a way that they do other diseases.
You know, you're right. It also depends where you are. But diabetes, and in particular pre-diabetes, the early stage of diabetes, is actually a vascular disease. It's at that time that plaque grows really logarithmically. Over the 10 to 15 years in which you go from somebody who's pre-diabetic into someone who's formerly diabetic, the amount of plaque that is visible in people's arteries grows extraordinarily. So that is the opportunity for patient and physician to be able to intervene and make a meaningful difference. Now, once diabetes starts, think of everything you enjoy, like vision, the use of your hands and legs, being able to feel your legs, being able to see, being able to urinate on your own and not have to have dialysis to be needed, to have all of your toes and all of your fingers, and to know exactly, as you're reading something on a piece of paper, what it says and being able to speak it. So I'm talking about stroke, I'm talking about heart attacks, I'm talking about maintaining patency, openness of arteries in your legs, diabetes, and if you smoke on top of that, it's like getting 1 and 1 and getting 7.
Multiplies.
Absolutely right.
Okay.
So the bottom line is that when your blood sugars are high, it really essentially gets at your small blood vessels. So that's your eyes, that's your kidneys, and that's the blood vessels around your nerves. So that's the sugar issue. And then the heart attack and stroke risk is doubled to tripled. So in diabetes, we think of it as a disorder in which cholesterol and blood pressure are that much more important. So, so think of the person who's morbidly obese, who hasn't exercised, eats most of their meals out of a Dunkin' Donut box, and visits the Colonel and the Golden Arches frequently.
Right.
These are individuals who, probably view the idea of them being good with their diet of having the fried fish at McDonald's, rather than 2 cheeseburgers. And
everything is relative.
I hear you. Okay. And ultimately they may be right. Certainly, I'd rather have someone. I'll take what I can get, so to speak. But if someone gives me a choice, I'll tell them to make a left at McDonald's and go somewhere else. But if they say, look, I'm going to McDonald's, I say, fine. Then instead of the fish, try the grilled chicken. And if instead of the hamburger, try the fish. Avoid the cheese on top of the hamburger. And, if you're diabetic, try to have it on one piece of bread and don't have the fries.
Gotcha. Now, we talked a little bit, so just to frame it for people, so there are non-modifiable risk factors. Can't change your heredity, can't change your age, can't change your gender.
Right.
Well, if you do change your gender, it doesn't change your risk profile, but
Yeah.
but
Look what happened to Michael Jackson.
okay,
Helped him, right?
and it didn't help him.
No.
And then also race. And then what we want to talk about, because what we talk about all the time, is the modifiable. So think about this, people. There are some things you can't change. We're not going to worry about those, but the ones you can, that's what we're going to talk about tonight. So what are some of the things that people have to worry about? You mentioned age 30 and 40, okay, for heart disease. So I don't know too many 30 and 40-year-olds that have seen a cardiologist or that are even worried. You know, I bet some doctors aren't even doing total lipid profiles on these patients. So what do we say to these people?
So the people I see very frequently, you got to remember, I'm seeing a selected population.
Okay.
People will look, they'll have concerns about doing something, and you're more right than you know, because many physicians are telling the guy, don't worry.
Exactly.
You don't need
You'll worry
this.
in 20 years.
You don't need this, right. And they say, well, wait a minute, you know, my father's brother had a heart attack at 55.
Right.
Right? Or the other way, one of my father's good friends dropped dead on the Metro North platform in Scarsdale. And now I'm scared because that guy was active, he played tennis, he worked out every day, and no one can figure out why this guy's dead.
Yeah.
Okay.
Or the person that comes, they're 50, their brother died at 51, and everyone in the room checks their watch.
Exactly right. Exactly right. And that usually when that happens, the people that end up coming in is the wives drag the husbands.
Okay.
And then you really know what's going on. And then typically there, it's a guy who has been reasonably active in high school, maybe a jock in college, and then comes the financial pressures of early relationship and early family. The fact that when you have 3 and 4-year-olds, very frequently you're eating what they're eating, which means chicken fingers, mashed potatoes, and other bad foods. And you eat at all times of the day, and when they wake up at 3 in the morning, you're helping yourself to something in the refrigerator. So these guys gain 15 or 20 pounds. Anything that was in their family history gets expressed. I mean, you can suppress genetic predisposition, but you can't prevent it. But if you have the predisposition to have high cholesterol, high lipids, and high blood pressure, and you're good to it. You're aerobically active. You're watching your diet because there's a coach kicking your ass, telling you not to be overweight, and you don't smoke. And then it switches. You don't exercise. You eat incorrectly. You gain weight. Don't sleep well. Maybe gain weight and have sleep apnea. Okay, and then all of these things together, and you balloon 20 or 30 pounds. Your blood pressure goes up. Your lipids go the wrong way. And now at age 45 or 50, you become a candidate for a cardiovascular event. And I really wish I could tell you that we don't see people in their 30s and 40s with this. Certainly, there's not as many in their 30s. Believe it or not, the ones we see in their 30s are people from India.
Really?
Yeah, the Indians have this terrible, terrible lipid profile. The Bellevue Fellows, the cardiology fellows at Bellevue, are constantly amazed when they see some slender Bangladeshi or Indian man or woman, no diabetes, non-smoking, and they have these huge anterior wall heart attacks.
Related to diet?
Yes, what it is this is genes, and here it is genes, ethnicity, and geography. So when they were farming and eating all natural things, not eating a lot of saturated fat, and they had no SUV to drive to Taco Bell.
Right.
And the most they did was they walked behind an ox, or if they went shopping, they took a bicycle. They then either move into town, right, and they become more motorized, westernized, and their diet goes with them, or they do it even worse and they move to the UK or the United States. And there was a study called the Cambridge Heart Study where they tracked individuals from India as they moved to the UK, and they dropped like flies. Okay, so it is the food, when you take the Indian genes and expose them to a high carbohydrate, high saturated fat diet and no exercise, they develop bellies, their lipids go to hell very, very quickly. I'm sorry for that language. They go to heck very quickly. And the next thing you know, you have young individuals with horrible heart attacks. So it's a matter of ethnicity. But so we see these kind of people. And the other way to look at it is, there's no badge of honor of having a heart attack at age 60 or 70.
Absolutely.
And if you can try to avoid it, I think I mean, there's some of the real hardliners say an intervention isn't worth it if it doesn't prevent mortality. So I agree that's important. Dying stinks. But having a non-fatal heart attack is something I don't know anybody who wouldn't like to avoid.
Absolutely. And for some people, it changes everything
Exactly.
from that point forward.
Or worse, a non-fatal stroke.
Yeah, exactly.
So I'm going to confess here. What I do is I cheat. I talk to patients about strokes because I can scare patients about strokes
Agree
a whole lot
100%.
easier. I know running a rehab center, even though your focus is pulmonary, I know you do musculoskeletal rehab.
Absolutely.
And there is nothing more devastating than somebody who was functioning productive, who now has lost use of their dominant side, which means their
Absolutely.
speech and or understanding of speech has now been compromised, and they have a grandkid, or maybe they have
100%.
children that they want to watch get married, and they're sitting there happy to be able to control their urine.
Well, it's like people say all the time when someone says to me, "You got to die of something," and I say, but you might not die. You might have a stroke and live for 15 more years.
Exactly.
And that's what scares me more than anything else.
As it should.
Death, you're done, and it's in a stroke. Now it's like your whole lifestyle has
And
changed.
go another way, you running cardiac rehab know very well that someone can have a huge heart attack.
And come back.
And it can come back. They can come back to work. They can enjoy emotional relationships.
Absolutely.
They can take a little Viagra and do what they have to do. But a small, teeny stroke
Absolutely.
can take them out of the picture.
Changes everything.
So, but you know what? Same risk factors. Exactly the same. Smoking, diabetes, high cholesterol, high blood pressure. Exactly the same. Just a question of roll the dice, which artery is going to hit you.
Yep.
And I think that people don't understand that. And the problem has been we've gotten so good fixing hearts. So either we prevent, we put in stents like crazy, because God knows the interventional cardiologists need to drive Porsches.
Okay.
And I'm jealous. And people are happy to do it because the American philosophy is, why would you want me to diet and work hard at things?
Right.
All you got to do is lie down on the table, someone puts some scaffolding in my coronary arteries, and I feel better.
Right.
None of this medicine stuff, And of course they're not being cured because atherosclerosis is everywhere.
Never stops.
Never stops. So a stroke regrettably gets your attention. So what I do when I want to get someone's attention is that.
It's a good tactic. Now, let me ask you this. The majority of people listening right now have some form of lung disease, COPD, pulmonary fibrosis. We do have a lot of people with pulmonary hypertension. But for these people, everyday life is about shortness of breath
Sure.
and inhalers.
Sure.
And how do we, take our oxygen and our meds and things like that. So for a lot of these people, we have this kind of giant snowball of I can't breathe. And the heart often, I feel, gets overlooked. Or maybe their lung disease doesn't allow them to do the type of activity that, let's say, the average person would elicit
Correct.
angina.
Right.
So they may not even know. So what do we say to these people at home? What do they need to do, and what conversation do they need to have with their doctors about what's...
So what you talk about is exactly the parallel of someone who survives breast or prostate cancer. Their blood pressure is high, their lipids are high. They're happy they just made it away with negative biopsy results and clean scans.
Right.
And in the meantime, they've been eating Dunkin' donut holes and Chuck E. Cheese, and their cholesterol levels are high, and they may even be smoking. So there's a whole move now in that group to try to do what they now call cardio-oncology, to try to get at them. But in regards to what you talk about, that problem is even worse, because there are people who can have what we call an anginal equivalent. More common in women, more common in older people, more common in diabetes. So immediately you have half the population with women.
Before you talk about the anginal equivalent, talk about angina for a second,
Sure.
because not everybody knows what that is, and talk about the different kinds of chest pain you can
Angina
get.
was defined by an English physician named Sir William Heberden. It was defined in 1813. So for 300 years, we've been walking around knowing that it's described as a discomfort that he describes in very flowery language as a gripping pressure, which is usually in the center of the chest or the left side of the chest, the precordium, that comes on with exertion and goes away when you stop. It is more likely to happen if you walk up a hill into a cold wind, particularly after a meal. So the times that people will tell you about this is to say, Doc, I was fine, I went out to eat with my wife, we parked the car a block or two away, we couldn't find a garage spot nearby, or we're in New York, I couldn't get a cab, or the subway station was 2 blocks away. I walked up and, I felt this unusual sense. Now, if they're older, diabetic or female, they are more likely to have non-typical angina. So what I just described to you was classic textbook exertional angina.
Okay.
And Heberden called it angina pectoris.
Okay.
So atypical angina would mean that instead of this gripping pain, it may be neck discomfort, it may be back discomfort, or it may only be shortness of breath. So you have an even harder job. So for you, when you're looking at a middle-aged individual with cardiovascular risk factors, and they're complaining of shortness of breath, you may actually be dealing with someone who's having mixed problems.
Right.
And you know that if they're desaturating when you exercise them, that adds even more stress, and then make it one worse. Some of these people have been unfortunate enough to have long-standing lung disease. We were talking about this in the beginning. I think pulmonary hypertension is such a terrible thing to have. We know not nearly enough about treating it, and it is not diagnosed often.
Often misdiagnosed, exactly.
Exactly right.
So,
and you only find it, and this is not going to sound nice, there are people who do echocardiograms in their offices, and regrettably they do them because they'd like to get information, but also because it's a source of revenue.
business.
Right. And to do an accurate pulmonary artery pressure, you got to work. You got to spend some time. And also it means your technician needs to give you, the physician, the right information. So as they say, garbage in, garbage out. So if you don't get a good picture, you're not going to make a diagnosis. And I can't tell you the number of times that we've seen people who either due to, just look at it this way. If the heart is stiff, take a water balloon, okay? Trying to blow a water balloon up and it's a thick water balloon, you're going to have to blow much harder to get that balloon to expand. Right. So what happens is the amount of pressure you're placing to expand that water balloon goes higher. Well, think of it now as the blood coming in from the lungs, right, going into the heart.
Right.
This then gets backed up. And as that pressure gets higher and higher, the pressure in the arteries going to the lungs increases. So just without even primary pulmonary disease, simply from having a stiff, non-compliant left ventricle, you can develop pulmonary hypertension, right?
And one of the tricky things also is that we have patients who their baseline is shortness of breath, and so then, for a lot of, I hate to say it, but for a lot of physicians, pulmonary hypertension isn't even on the radar.
That's right.
Especially because shortness of breath is attributed, well, you've had COPD, you have stage 3 COPD, it must be that.
And it's not right necessarily.
Yeah.
And it may be multifactorial. So, and you know why people don't look for it? Because up until recently, there was not even any specific treatment for it. Right?
Exactly.
Right? So there was no pharmacotherapy, which meant docs went, wait a minute, why should I worry about something I can't treat? So, which is a huge mistake. Because the majority of people, if you tell them, look, it's not going to be pretty, but if you wear oxygen, you may be able to move.
Right.
And not only that, you may not die. You may not be messing up your heart. They would say, all right, look, bad break. But, now that they have these small canisters of refillable O2, and they can walk around like they have a large, pocketbook over their shoulder, there are people who do it.
Absolutely.
And it works.
So now for the people...
And more importantly,
Sorry.
exercise. If what you do is, when you're over the age of 25, you're not improving your heart or your lungs, you're improving the way your skeletal muscles work so that your lungs work. Well, you are improving your lungs, but you're not improving the heart. And if what you do is make your peripheral muscles more efficient, that means that whenever blood passes through them, it extracts more oxygen, which means your lungs aren't working as hard to get air in, your heart's not working as hard getting blood around, and that is where the exercise training goes on. And I'm not sure that enough places approach this in the right way, because it becomes more like feel-good centers. They're
not pushing people.
Right. It becomes like a stage above the why.
Well, in a lot of places they can't, because it'll be one clinician and 8 patients, and they go in a room and everybody does 10 minutes of this and 10 minutes of this. In some places they're not even doing EKGs.
Yeah, that's.
Or they'll do blood pressures at the beginning of the session and blood pressure at the end of the session.
Required.
Yeah, that's what's required by insurance. Right. But I say to people, if you want to know how a plane flies, you can't check it on the runway before you take off and after you land. And it's the same kind of thing. But so for the people at home, If they're listening to this and saying, well, I don't want a heart attack and I don't want a stroke, if they've never had what tests before,
Sure.
what should they start asking their
Good
doctor
idea.
about?
So first of all, number one, you should look back and say, what does my mother and father or brothers and sisters have?
Okay.
So if you have high blood pressure and high cholesterol and heart disease in blood relatives, you immediately need to be worried. Whether you're fat, skinny, it doesn't matter, okay? You can't say it's not going to hit me because daddy smoked and he was fat.
Right.
Guess what? There were genes involved. There were plenty of people who smoked and were fat that never had bad hearts. So bad news, not fair all the
If
time.
it's in the family,
It's
you have
there.
to think about
Exactly
it.
right.
Okay.
And the chance goes even higher if your sibling has it. So if a sibling has it, you have a 1 out of 2. If a parent has it, it's like 1 out of 3 or 1 out of 4. So, and if both parents have it, it's a sure thing. So if both of your parents are hypertensive, just get used to it, watch your salt intake, and know that at some point in your adult life, you're going to need medicine. So that's one. Number two, look at same thing with cholesterol. Look at whether anybody in the family, did grandma or grandpa die in their 40s of heart disease? Do you remember uncles, frequently in the hospital getting stents or bypasses? If you don't, and if you're lucky and everybody lives into their 90s, say, kiss your mother and thank her and keep going. But if you don't, which is most people, you need to be alert. So that's two.
Can you explain the difference between good cholesterol, bad cholesterol, and what else they need to know about that?
So the way cholesterol is a fat, and I'm sure everybody's had the opportunity to get some oil in water, and you see it just sits there like a little droplet and won't dissolve. So the whole idea of oil in water. So in order to make a fat dissolve in a water-based solution, you need to attach it to a protein. So the way it works out is you have a lipoprotein, and that's HDL, high-density lipoprotein, and LDL, low-density lipoprotein. But they each have
So HDL is good cholesterol?
We'll get into that.
Okay,
It is felt to be the good stuff.
Okay.
LDL is unquestionably bad.
Okay.
Think H for happy, L for lousy, and
Okay.
we'll do okay.
Okay.
Go to the bad one first. So LDL LDL carries cholesterol, and when there's enough cholesterol on LDL, it can be deposited in tissues.
Okay.
Which means, and what happens is, it actually gets inside the blood vessel. This is atherosclerosis or plaque development 101. Cholesterol gets inside the tissue where the body recognizes it as foreign. Now, we were never supposed to have cardiac disease because we weren't supposed to smoke and do other stupid stuff. We were supposed to eat what was there in front of us.
Berries, find berries.
And chase after them.
Okay.
Okay? Which means even if you ate meat, it wasn't meat that was fed steroids. It was meat that was pristine. And as long as you were trying to not be someone else's dinner, you also stayed in fit. Otherwise, you were someone else's dinner. And the seafood we ate was also pristine. So, yes, we did eat, that's the whole paleo diet stuff. Yeah, we did eat meat and fats.
Paleo diet, we talk about it every week. And you know what's really interesting? And you maybe know this too. So one of the things I love doing is I love finding people around the world, and they find us now, but who, despite unbelievable odds, pulmonary hypertension, COPD, pulmonary fibrosis, excel. And we've got like a dozen of them now who like have severe disease, but they're athletes and they're superpowers. And we're going to talk to one in a little while, Russell Winwood, who's got stage 4 COPD and is going to run the marathon. But what we find is that for these anomalies, they're all doing very similar things. And you talk about the paleo diet. So they all have super clean diets. They all exercise like beasts. They're all doing some kind of stress management and social support or things like that.
Right.
And it's like almost like it becomes human nature for them.
Right. And the other thing is, what people we kind of got it wrong. Initially, we thought it was all a matter of dietary cholesterol. It's not dietary cholesterol, it's dietary fat. The other thing is that what you eat, you wear. If you don't burn it, you wear it. That's kind of simple. If you put gas in your car and you don't drive it, it's going to eventually overflow the gas tank and it's on the floor. Same deal. But the thing that we're eating more of is sugars. So what's killing what's killing us and what's causing the obesity and diabetes and accelerating atherosclerosis is not whether we're eating pate or whether we're eating beef. It's how much sugars we're eating. So as much as a former mayor might have had his interesting ways. He wasn't totally off the mark in trying to get people to not drink huge 32 ounce
soda, right?
sugary
I mean,
soft drinks.
there's an article every week about the 12 things soda does to you,
Right.
and none of them are good.
No, and particularly sweetened sodas.
Yeah.
So, and if you go down south, they don't know anything else except sweetened sodas and what they call sweet tea, right? So that is why the southeast of this country is the stroke belt of this country. It is, but anyway, so I tell people to then, so once you look at your family history, and we were asking about LDL, so LDL is the bad stuff. HDL can act like a garbage truck. So HDL can actually take cholesterol out of the tissue and bring it back to the liver where the liver gets rid of it. So think of it as reverse cholesterol transport.
Okay.
And one of the things we know is that it's not just how much HDL you have, but how well it functions. So what would make you not have a non-functioning HDL? One of them is your diet. Turns out that when we eat a lot of very like sausagey processed meats, okay, there are breakdown products in our gut that cause oxidative stress and actually modify the kind of HDL we make into being non-functional, which means this HDL no longer acts like a garbage truck, but it just doesn't work. The other thing that happens is when you're diabetic and your sugars are high and a fat called triglycerides are high, the HDL you make doesn't work. So you could have great numbers of HDL, but imagine this way, it's like having garbage trucks with no doors. They're circulating around, but they can't pick up any garbage.
So this is fascinating. So you're saying not only do you get the negative side of eating the bacon, of eating the sausage, but that also decreases the effectiveness of the good cholesterol.
This was discovered by a guy at the Cleveland Clinic, and actually, you notice that I'm the clinical director of my unit. The guy who's the overall director is an MD, PhD, who's a researcher, and he and a guy named Stan Hazen made this discovery and published it. So now the whole big deal is called the biome. This is the microbiome. These are our interaction with the bacteria that are living inside our gut. And it turns out that this may be more
That's
important
turning
than
into
we think.
everything. Exactly.
Right.
The gut is the key to everything. Exactly.
It's amazing. So so the people that were running around holistically, were not completely wrong. The only problem with believing that's the whole answer is nothing's the whole answer. As a matter of fact, if someone says, I have the answer, I go, I know you're wrong. Because there's no such thing as the answer.
Especially for every person.
Exactly correct.
Exactly.
So those are the two lipids. So you're going to want to know. So if your HDL is normal HDL should be for a man over 40, over 50 for a woman, right? And LDL is something that they've been debating about. However, we at NYU in our prevention section have gone, online. We have some videos on YouTube. We've published some stuff.
I will put links to those. We'll link to those as well. We'll make those available.
So what we have done is we firmly believe that there's several things. You can't be too rich, too thin, or have too low an LDL. Okay? So LDL that's nice and low is something I heard. I was just as long as there was no one.
They're still in the tank.
As long as no one's making an escape attempt. So as long as the lower your LDL is, the better you are. So if somebody so what does that mean? It means you're going to.
And that's a blood test, right? You could look at your blood test and find it. You can even do it with a finger stick.
Okay. You can get it with a finger stick. So these things are now available very inexpensively, and there are health fairs that go on all the time. Particularly with the spring coming up, every time there's someone's occupying one of the main avenues, you can be sure that some organization is out there offering health screening, of which a blood test. A finger stick will probably be part of it. You can get a cholesterol, a blood sugar, and HDL and triglycerides.
Okay.
You'll know what's going on. And then it's very simple. You stick your arm out and have your blood pressure checked. So what you've done by doing that is identify two of the major risk factors. So it's, sometimes in medicine there's an abbreviation that says WNL, and someone thinks it means within normal limits. I think it means we never looked. Okay?
We never looked, right. It's like they say, if your respiratory rate is 18, you didn't check it.
That's exactly correct.
Yeah.
Right.
Okay.
So to me, it is for somebody to say, I never knew, and for them to look at themselves in the mirror and realize they look like Mr. Potato.
For the patient to say they didn't know. So you know.
So if you're gonna know how you feel, if you're within the sound of our voices, and you are somebody has the opportunity to walk, and you do walk, and you find it difficult to go more than 6 blocks or 2 flights, you need to have this looked into. One way, or you're either horribly out of shape, your heart's in trouble, or your lungs in trouble, or all three. That's the move.
Okay.
If you're looking, if there's heart disease in the family, people have died of heart problems. People, you hear about relatives having stents, bypass surgery, heart attacks. You should be looking into this.
And so how do you look into that? My grandmother's doctor would tell her, as long as I could still get my arms around you, you're not too fat. Okay. So the thing is, what does our patient take to their doctor to say, I heard Dr. Weintraub talk, and should I be having this? What should I have?
So anybody over the age of 30 should have a lipid profile.
Okay.
Okay. And then if it's normal, you can repeat it in 5 years. If it's not, you do something about it.
Okay.
Number one. Number two, everybody should have their blood pressure checked at that point. And more compelling, if there's a family history, right?
Should people be checking their pressure at home?
So we advocate that. I'll tell you the truth. Because I don't know about you, but so many people I see on it every day, I see somebody whose blood pressure is 170 because they just don't like being in a doctor's
White
office.
coat syndrome.
Right.
Yep.
I could walk in wearing swim trunks and it wouldn't matter. That would
Swim
scare
trunk
them.
syndrome.
That would scare them. Right?
Yep.
They would, oh my God, you're not my doctor. So this can be something, and then I sit with them and I chat in the room and I take their blood pressure 3 or 4 more times and it gradually goes down. So we published and others have published data that shows that taking your blood pressure at home can be very valuable. And really, what's to say that an isolated blood pressure done at a random time of the day is going to be the one thing that's going to judge the adequacy or not of your blood pressure control.
Right.
So we tell people, you get a cuff, one of the automated cuffs, preferably the upper arm, not the wrist.
Not the wrist. Okay.
Preferably not. They're sexier looking, but you get better results with the upper arm.
Okay.
And you measure it within a half hour of getting up, and you measure it sometime around 6 p.m., give or take 2 hours.
Okay.
And you do it 3 times. First time, throw out the number, because you may even be afraid of that.
Okay.
Average the next 2.
Okay.
All right? So this way you get a rough idea of what's going on, and then you can then go to your doctor, say, listen, Dr. whoever, I've been monitoring my own blood pressure. I borrowed my sister's machine. I went to Dwayne Reed and I bought one for $29. And actually, I think in Consumer Reports there was recently a review of some of these machines, and they're not necessarily the high-end ones are good.
Okay, we'll try to get that for you as well.
And I think that you measure this, and it gives you reason to know if your blood pressure are all terrific, then that's one very important piece of information that you can be a little bit more...
One less thing to worry about.
Exactly right.
Okay.
And that's something that you can do on your own.
Okay.
And some of the machines that you pay extra money for are ones that might have a memory in it, but I don't think you need to spend an extra $50. Most people can write a number on a piece of paper.
Yeah.
And so they got blood pressure and cholesterol.
Okay.
And then at the same time, if you've gained weight recently, particularly around the belly, if there's anybody in the family with a history of diabetes, you should be worried about diabetes. Mm-hmm. So either a finger stick to check a fasting blood sugar, or what's probably more important is a blood sugar that's done a few hours after you eat. I'll tell you why.
But these are things that are going to get done in the doctor's office,
They should.
right?
They
Okay,
should.
yeah.
Yes. Or they get something called the hemoglobin A1C, which a little more complicated, but it's a bit more accurate for detecting diabetes. So, but the things that you can do on your own is check your history, check how you feel, check how you look, right? And then you can do your own blood pressure. And what you've done immediately, if you're skinny, your family history is great, and you don't smoke, and your blood pressure is good, go out and have a beer on me, okay? But
You heard it here, folks. Getting his credit card after the phone.
yeah, right. And if you believe, anyway, and if not, then it's up to you, or to then take this in your hands and decide. It's the Clint Eastwood question: do you feel lucky?
Okay.
Okay. And if you don't feel so lucky, or you don't necessarily want to have to experience sleeping on a plastic mattress in a hospital ER, then the right thing to do is to take it upon yourself, because no one's going to come looking for you.
Go to the doctor. Tell
Right.
them. Now, what about this? There are doctors that will do an EKG on every visit. Valuable or not valuable?
On entry, yes. Every visit, no. Somebody with heart disease,
Resting EKG, is that valuable?
Resting EKG is valuable for people on certain medicines, but for someone who comes in for their initial screen, and then you're following them just to either do blood tests or blood pressures, the answer is no.
It's only if they're having an event at the moment.
Exactly right.
So
or if they tell you, look, doc, last week I had 3 hours of chest pain.
Yeah.
And you want to see if something happened.
Okay.
Because there would be a footprint.
Did you have a heart attack?
Yeah.
Okay. And so what does that person need? So for the patient sitting at home, and again, in the context of lung disease, so for the person who's so short of breath that maybe doesn't even know that they would get angina if they could walk up 2 flights,
Correct.
or if they could walk to the mailbox.
So now, how did you get so short of breath with lung disease? If you smoked, right away you have another risk factor for heart disease.
Okay.
Right? If it's a matter of asthma, and there was no secondhand smoke, which is important in the house, and there was no, and you have none of the other stuff that we just mentioned, then you may be a little less concerned about concomitant cardiac disease. But the majority of individuals who are going to have serious enough COPD are going to have an etiology that may point towards cigarettes.
So what would your test be? What would your first, what would you think is the test that's
Thoughtful
going
doctor. Okay. So that means you feel, okay. One interesting way to do this is to have an examination and feel their pulses. So somebody who has diffuse atherosclerosis, you may either hear bruits, a noise in their carotids, or their pulses in their feet may be diminished. So that's one. And then I think it's all very variable. I guess if somebody, I would do a stress test at that point. So if someone comes to me.
Before you go on, here's a thought for people. I think of myself, and maybe I've seen 5 doctors in the past 10 years, okay? How many of them have listened to my carotids? Not all, and not half of them. How many of them have felt my pedal pulses? Which we're talking about, how many doctors have put their stethoscope and listened to your neck or felt the pulses on your feet?
I think
not everybody does it.
I think
You do, yeah, of course you do, but no, not a lot of people do that.
But this way, if you have good bounding pulses in your legs and there's nothing going on, that makes me feel more comfortable. If I hear a noise, making me believe that the blood flow is constricted in the carotids, then that didn't happen by chance, and there's probably this, whatever is here, and whatever is in your legs.
That's what we say all the time. If you have atherosclerosis in one place, you have it everywhere.
Everywhere.
Exactly. So now the stress test you talk about, okay? So for a lot of our pulmonary patients, it's a super anxiety provoking test, and rightfully so, because a lot of testing protocols are too hard and too fast, and people get short of breath. So how do we make sure we get the right info? So
Noah, we were just discussing this. Noah and I have a legacy with a woman at NYU who used to actually work for me. As you know, I have a pulmonary background as well. When they asked me, when I was finishing training, I was asked to be a chief resident, and I'm a lousy administrator. So I couldn't make up my mind between pulmonary and cardiology. So I did a pulmonary fellowship and a cardiology fellowship. So that when I finished training, I was in the exercise lab. And a woman who's a type 1 diabetic came to work for us. Her first name was Brooke, and her last name Benson. And there was the Benson protocol that you use here. And we were just commenting on the fact that is a much more civilized, appropriate protocol for somebody, A, who's older, and B, who may have pulmonary disease or orthopedic limitation. Because the standard protocol that's done by a guy named Robert Bruce protocol, starts at 10 degrees incline, which many people can't tolerate at all. And even at 1.7 miles an hour, which is a modified protocol on no incline, can be can be stressful for them. So having the opportunity to watch their cardiogram as they exercise, having the opportunity to see when they walk and they get short of breath, are they wheezing? God forbid you listen to their lungs and do an examination.
And our pulmonary patients should also be having their pulse oximeter checked as well, right?
Absolutely right.
Okay.
Absolutely correct. Absolutely. So these are things that could help. Now, one of the things I'm kind of a crusader for is that what docs a lot of them like to do is immediately do a stress echo or a stress nuclear. And in many cases, you can do without it, and it saves thousands of dollars.
See, I thought you were going to say the opposite. I thought you were going to say do a stress echo.
No, what I would do, first of all, if I'm worried about shortness of breath, and I find someone who has absolutely no EKG changes and look, it depends on the patient, Noah. If I have someone with long-standing COPD and I'm worried about pulmonary hypertension, then I'm going to do an echo, and I might as well do a stress echo.
And that's something that's a real concern with a lot of pulmonary patients, right?
Exactly.
So pulmonary hypertension should be thought of really if you've had COPD for any length of time,
Absolutely, right.
Okay.
So that's true. I do more stress echoes than I do stress nuclears, and I think that's because of my background with pulmonary, because I want to be able to look at their pulmonary artery pressures, and you can't do that with a nuclear, right?
Okay.
So, and the nuclears are twice as expensive. A nuclear stress test can cost over $2,000. The stress echoes are quicker. You get more information, and there are fewer false positives. There are a lot of false positives on the nuclear studies. But if I just want to do a screening test, let's say someone doesn't have insurance, or they don't have good insurance. So before I start, maybe taking money out of someone's pocket, we'll do a standard treadmill test. And anybody who's good could look at a patient and get a rough idea what's
By
going
looking
on.
at them,
Exactly
by seeing
right.
how they act. Okay.
If they're cold and clammy as they're exercising, you're worried about a circulatory issue. If you watch someone on the treadmill and they're using every accessory muscle they possibly can, their sternocleidomastoids are coming into play,
Right.
and they're wheezing and their eyes are bugging. This is pulmonary,
Okay.
And so you try to use a little clinical judgment, and then at that point, if the EKG doesn't show any abnormalities, you can pursue a pulmonary issue. And then if you're not sure, then what you do is appropriately. You
Go
do
further.
a stress echo. Yeah.
Okay, gotcha. So for the patients at home, if you have had significant COPD, pulmonary fibrosis, pulmonary hypertension, ask your doctor, do I need a stress test? Am I going to benefit from it? And how do you get a doctor, like we're talking about the Benson protocol, most people don't know about that.
You're exactly
How do we
right.
get somebody else to do that test?
It's a very good question. They probably have to contact you or I or someone at NYU, because that's where it was made. There are other protocols that can be done. There's one protocol that starts even quicker, at the bulky protocol. It starts at less inclination. I think what you need to do, one of the things that we talked about is I see too often that someone goes on the Bruce protocol and they literally don't exercise a full minute, and the guy has the chutzpah to send a test back to you,
Right.
saying the patient exercised 47 seconds. Here's
And they
your
don't have
test.
heart disease.
That's right.
To me, I say to patients, that paper you can use for something, anything you want, because it's useless to us.
Let's put it in the birdcage.
We get those tests and we've gotten no information, and sometimes we get that test and it says you don't have heart disease, but you didn't do enough to check it out.
Exactly right. So I think in those cases, what you'd like to do, and also let's be realistic. I'm not worrying about whether the patient can run. I'd like to know whether the patient can walk a little bit. So doing something where they'd get at least 6 minutes of exercise, I think would be important. So, and the other reason to do that is, because let's say I get somebody who says, all right, I've seen the light. I want to be able to do something, and I know I've gained 30 pounds over the last 20 years, and I'm a little worried about this shortness of breath, okay? And whether it's deconditioning, cardiac, or pulmonary, I'm going to want to tell him to exercise. So before I tell him to exercise, I may want to make sure that I'm not dealing with a guy who has a serious cardiac problem. And so doing a stress test is a very smart thing to do, because this person may then say, I'm going to exercise. And they're going to go out walking, and they'll go out walking on one cold day, and they'll be found on the street, or worse, they go to some health club, and regrettably, you and I know that the individuals in many of these commercial entities,
Trainers are gonna,
they're going to push you because that's what they're paying to do.
Right.
But if you, God forbid, go down, you're in deep trouble.
Right. A lot of times we tell you, and I say it before everything, to check with your doctor first. And people think that we're afraid of getting sued. And it's like, we're not afraid of getting sued. We don't want to send you out, onto the beach of Normandy and say, hey, go out and exercise, and then something happens to you. We're saying this because we know that there are real things that can happen. And especially when you've been limited by shortness of breath for so long, we don't really know what your heart can do because it never gets a chance.
Right.
Yeah,
It's
exactly.
It's like it's on the verge of fatigue. Fatigue
Exactly.
can be caused by so many things. Shortness of breath can be caused by so many things, which is the reason why I don't want to immediately do a $5,000 workup. But the first thing you got to do is think. Patients come to me or you, they're not paying me just to do procedures, they're paying me to think. And then after that, depending upon the degree of urgency, the degree of severity, the amount of testing that has to get done will be done. But or you can say, look, you don't even need a test. I know what you got. And I think that there's and in so many people, it's going to be multifactorial.
Absolutely. So we're going to go to Russell in a minute for a few minutes, but before we do that, three take-home points that lifestyle changes that you feel would go the furthest in terms of helping someone prevent a cardiovascular problem.
Okay. Watching the sugar intake that you have, more than fat. So avoid anything sugary, the sugared soft drinks, stay out of the fast food places. Anything white is bad, white bread, white rice, white potatoes, all those are bad. Number
What
one.
what would they have instead?
They all have brown rice instead of white rice.
Okay.
Whole grain. If you're a bread eater, it should not be white bread or even a whole wheat. It should be whole grain. Why is that? Because whole grain doesn't metabolize as quickly in your stomach, stays in your stomach longer. You don't get a spike in your blood sugar and then go eating more afterwards. And then instead of white potato, actually, believe it or not, sweet potato.
Okay.
And then even if you like pasta, a pasta meal is not your best answer. All right, you want to have pasta as a side dish, go right ahead, but not as a main meal. That's one, because of the sweets and carbs. Number two, some degree, again, trying to weight gain. So if you have put on, if you're a weight, you can find your BMI. It's a program in you can download it into any iPhone or cell phone, or go online and just Google BMI. And if your BMI is greater than 25, you got to think about it. If it's greater than 30, you have to do more than think about it, because that means you're obese.
Okay.
And the other thing to do along with that is measure your waist circumference. So if you're a football player, you may have a huge upper body, but your BMI may be enormous, but not you're not someone with a lot of fat. So what we worry about in a man is a waist circumference more than 40 inches and more than 35 inches in a woman. Okay.
Interesting.
All
So
right?
take out your tape measures, people.
And that's one of the things we do in our office. That's a vital sign.
I know, that's why I don't come. It's too embarrassing.
It's a vital sign. That's one of the other things we do along with pulse oximetry. We do pulse oximetry in everybody. Everybody.
You do? Okay.
Yeah, everybody.
Cool.
Well, I brought it in. I mean, I just think one of the ways you're going to know, if you have someone with a resting O2 sat that's in the low 90s or high 80s, you got something to think about. So that's one. So now we have your weight and your waist circumference. We have the sugar intake, and then finally stop smoking.
So sugar, weight,
Smoke.
exercise, smoke.
You got it.
That's it. All right. Awesome. We're going to go now to Australia.
Can I go?
You want to go?
No, to Australia.
To Australia. I'm supposed to be in Australia right now, as a matter of fact, but instead I choose to be with you. We're going down under to Russell Winwood. Russell, are you with us?
I'm with you now. How
All
are
right,
you?
I'm great. And today happens to be Russell's birthday, so happy birthday, Russell, 49 years old. So let me tell you about this guy. Russell Winwood is 49 years old. He's a super athlete marathoner. He has stage 4 COPD. Okay, he has less than 30%, and his most recent lung function test said 25%. But despite that, Russell Winwood is coming to the U.S. for November 1st, where he's going to run the New York City Marathon. And he's going to run for the American Lung Association, and Pulmonary Wellness is going to be helping out with that. And Russell, welcome to the show. Thank you so much for being here on your birthday.
It's a pleasure to be here, Noah.
And so, Russell, why don't you start us off? So you tell us a little bit about your story. And you know, the thing is, as I mentioned, I look for people all around the world who sort of succeed in the face of these things that would normally be terrible. We're not trying to say that if Russell can run the marathon, you can run the marathon. But Russell, you know, we try to take these people and learn, well, if this is working for him, what can we apply to everybody else? So Russell, start us off at the beginning. I know you were asthmatic as a child.
Yeah, so I was diagnosed as asthmatic when I was about 10 years old. And I lived a fairly active life as a kid. Back then, asthma plans didn't really exist, so you had your reliever inhaler, that sort of thing. During my life, I probably made a few lifestyle choices that weren't the best. I heard you talking before about smoking. That was one of them. So I went on and become very unhealthy. At the age of 36, I had what the doctors believe were a stroke. They couldn't come to any definite conclusion on that. And that, as you were talking about before, was a life-changing moment for me. It was about then I started, I took up triathlons, and my life changed dramatically. From doing that, I lost weight, become healthy, more energy, all that sort of things.
So Russell, you say that they thought it was a stroke. A stroke is usually pretty clear. What were your symptoms?
Basically, it was Christmas Day in 2002. I had decided to go for a swim. I said to my father, I'm going for a swim, jumped in the pool, which was on the other side of the house. I got out of the pool, started to dry myself, and that was that. I collapsed. Fortunately, my father had decided he would go for a swim, come around and found me. The next thing I know, I was in hospital. I was paralysed. I could hear what was going on around me, but I couldn't respond. And the shortened version is, within the next 2 to 3 days I pretty much got everything back. The only side effect I've had is some balance issues. I can't ride a surfboard anymore.
You still have balance issues now?
Yeah, but not noticeable. No, I'm
Okay.
the only one who would know about it.
Okay.
So when I was in hospital for about a week, I think it was. When I come out, I had a meeting with the doctors, and they said their best guess was that I had a seizure, and they think it was related to a stroke. But
that's what Dr. Weintraub just said too. That's exactly what Dr. Weintraub said. He said it sounds like a seizure.
Yeah.
So Russell, you didn't just start doing triathlons. Let's talk about the triathlons you do. You do the Ironman, right? So tell us what's involved in an Ironman triathlon.
Okay, so you'll have to do the conversion. So for Ironman, it's a 3.8 kilometre swim.
2.4 miles. Okay.
180 kilometre bike ride.
100-mile bike ride.
And then we finish it off with a nice 42.2k run.
26.2 miles. So a full marathon, a 100-mile bike ride, and a 2-mile swim.
Yeah. They always say that the swim and the bike rides are warm up for the run.
Perfect. It's always good to warm up. So tell us, how did that occur? You went from smoking and stroking, as you say, to this. How did you start that up?
Well, look, I started doing triathlon, as I say, about 10 years ago, and just did smaller ones. I always wanted to do an Ironman, and actually before I was diagnosed with COPD, I was training for Ironman. But what I'd found is my times were getting slower. I couldn't keep up with my friends. I was getting breathless. But just more and more. And this, it wasn't a sudden thing. It just started probably over a period of 12 months. It got very noticeable. So I took myself off to the doctors, and through pulmonary function testing, I was diagnosed with COPD in 2011. At that stage, I'd only done short distance. Well, when I say short distance, half Ironman would be the longest distance I'd done.
And what stage COPD did you have at that time when you were first diagnosed?
I was diagnosed with stage 4.
Stage 4 right off the bat?
Yep.
Okay. Wow. So Dr. Weintraub, how do you explain this? That he is able to do, he's stage 4. Go ahead.
So one of the things that we know happens is the efficiency of oxygen utilization in his muscles.
Okay.
So, example, when every pulse of blood comes through, if a muscle is efficient, it extracts all the oxygen it possibly can, so the blood that goes back to the heart doesn't have a lot of oxygen left.
Okay.
Think of it if you're running a distribution center and you send out a truck that's filled, but they only unload half of it, and they send the truck back half full. You're gonna have to send out more trucks. So if his muscles have learned to be more efficient in extracting oxygen, that helps his lungs and his heart not be the rate limiting factor that they could be.
So he's unloading the whole truck every time.
Exactly right.
Okay.
And he may have been able to improve, because of conditioning, what you get with conditioning is improving his inspiratory volumes, right? And also his recruitment of peripheral lung tissue and capillaries.
Thank you for saying that, because we've been saying this for 15 years, and everybody says over and over again, you cannot improve lung function.
No.
And the reason is because they have you walking on a treadmill at 1.1 mile per hour for 30 minutes.
When I learned pulmonary, what we
you.
were told would occur is that, with training, you would then what was essentially functional dead space or physiologic dead space could be reclaimed.
But it's got to be high intensity workouts.
Right, and someone of his age who's already done what he could to mess things up, it takes a lot of undoing.
Okay, Russell, tell us about your training and your tell us about your whole program. So we want to know training. What do you do? What do you eat? What do you?
I talk about two different lots of training, basically in and out of competition. So if I'm just everyday sort of life, I generally do exercise on most days between half an hour and an hour. On the weekends, we would generally go for a ride, and that ride might be anywhere between an hour and a half and 3 hours. When we're in training, and Ironman training specifically, it can involve between 18 and 24 hours a week. So it's a lot.
24 hours of training a week?
Yeah, that's right.
Do you work?
Just going to
Sorry?
say.
Do you work?
I do.
Okay.
It calls, it's getting up early, and it's nighttime training. It's weekend. It takes over your life to a certain extent.
Okay.
And I hear people say, they haven't got time to do all this training, but what I've found for me, and this was a good example, so I've done 3 Ironmans, the last 2 were last year. Now, about 3 weeks ago, I did a team triathlon, which I did the bike part of it, which was 90k. Now, leading into that, I'd only ridden the bike 6 times since my last event, so I hadn't done much training. So I went and did the 90k's. After the race, I wasn't exhausted, I wasn't sore, and I was about 4 minutes slower than my PB. So I think I had a lot of residual left over from the volumes of training I'd done through Ironman.
Mm-hmm.
So I say to people, if you can build up your exercise capacity to a stage where you are extremely fit, you don't have to keep busting yourself every day. You can have what I call like a maintenance that keeps your fitness well and truly up there, but it's not taking over your life.
Was he a trainer? Did you train avidly before your event, before your stroke or seizure, whatever it was?
No, I was leading a pretty bad lifestyle before that.
So this all started how many years ago that you got serious about exercise?
Serious, I've always been on and off, but I probably had about a 7 or 8 year period where I went off exercise. I smoked, I drank and did all the bad things.
Are your parents athletes?
My father used to be a lifesaver. I mean, we're a fairly, I would say, active family right throughout.
And so, Russell, what are you eating? Like, do you have a special diet that you're eating?
Healthy foods.
Uh-huh.
What you're talking before about limiting sugar in our diet, that sort of thing. I'm a big fan of if it's man-made, don't eat it. If it comes out of the ground, then it's good to eat.
Good point. Good point.
So, I don't go to McDonald's or KFC and fast food outlets in general. In saying that, I must confess that after Ironman, the one thing I always crave is the cheeseburger.
Okay.
Dude.
Okay.
I think by at that point you deserve it. You probably incinerated about 25,000 calories.
Yeah, well, that's right. It's funny you talk about that. I did a report, a printout from my Garmin, my monitor, the other day about how many kilometres I've done since I was diagnosed with COPD. So in just under 4 years, I've done 15,700 of exercise kilometres.
Incredible. And what about medications, Russell? What do you take? Any inhalers?
Yeah, so Spiriva, Symbicort and Oxys are my regular inhalers, and my reliever I use is a Bricanol inhaler. The one thing I have been doing since being diagnosed really is I take zinc powder. every day without fail, and I don't get colds.
You eat it? You ingest zinc powder, you mean?
Chest infections.
You mean you ingest zinc powder? Like a
So I
supplement?
just mix it up with water, yep.
Okay, zinc is, yeah, that's a good thing.
He said 15,000 kilometers? Is that
Yeah,
what he said?
15, so Howard, I did the math, he's done 9,320 miles. That's a pretty good record, brother.
I might just say that for 4 weeks with that, my watch wasn't working, so there's probably a bit extra.
You're coming close to 10K.
Good
All right, that's awesome. Russell, tell us about this New York City thing, because we're super excited about it. I know the American Lung Association is excited about it. I know the Asthma Council of Australia is excited. Tell us how you're going to do this.
Well, it's going to be a different challenge. People say to me, well, you've done a marathon before at the end of each Ironman event, and that's true. But New York's going to pose some challenges as far as the climate. One of the triggers for myself, and I guess a lot of people with asthma or COPD, is cold. So I have a mentality, if you find it hard to walk up steps, you need to walk up more. And it's the same in our program. We'll put in nighttime training, early morning training. So we're training in cold conditions. So with the New York Marathon, it was a challenge.
You need to train in front of a car with the exhaust blowing in your face in the cold. That will get you ready for New York.
We're still working out on that one. I may be the one running in the mask.
Okay, that'll work. That'll work.
Yeah.
So tell us about the project, because I hate to ask people for them, but I'm going to talk for you. I'm not asking for me, but we are raising money for the American Lung Association, right? And tell us about your whole plan. So tell us when you're planning to come, how long you're going to stay.
Oh look, plan is we'll get there about a week before the race because I want to acclimatise. If I do have any issues on the plane, pick up a bug, it gives me a chance to sort of get over that if I have anything. I mean, to me, raising awareness is a big thing for COPD and lung disease in general, because there's not enough talk about it. We talk about heart attacks, we talk about strokes, but if you ask the average person if they know what COPD is, they wouldn't know.
Absolutely.
So this gives us a good opportunity to come over there, do something different. I can do things that most COPD patients can't do, so it helps me sort of shine a light on the whole issue and raise some valuable money for the American Lung Association.
And Russell, finally, before we go to audience questions for you and Dr. Weintraub, if there were 3 tips you would give to to say average COPD patient, there's really no thing, but recognizing that you are an anomaly, what are some things you would tell to the person who's maybe 20 years older than you and not running triathlons? What would you tell them?
Oh look, there's obviously the number one thing: if you're still smoking, don't. But apart from that, I have my things where I say diet. When I say diet, I shouldn't say that. Healthy eating choices. So eat healthy foods and take your medications. Take them when you're supposed to, as prescribed by your doctor.
Great point.
And most importantly, exercise and push yourself to your limits, because there's nothing wrong with getting breathless.
And take the sprays
It'll do
right.
you good.
And talk about that, Dr. Weintraub.
One of the things that I find in my office very frequently is that people get an inhaler, there's various kinds now, and no one teaches them how to use it. So what they are essentially doing is spraying the back of their throat, and then they can't figure out why it doesn't work. It's something that I feel almost, it takes time to do, but I almost feel goofy because this patient is going, gee, I don't feel any better on this medicine, and they're taking, as you are, a bronchodilator, they're taking a steroid, and there's timing of these things, and they're not inexpensive drugs, and if you don't take them right, they don't work.
And most people go home, and I say this all the time, they go home, they get a disc, an egg, and a pump. They don't know what they are. They've never been told that they're different from each other.
Right.
They've never been told that maybe the order that you take them in has a difference.
Well, I mean, look, you walk into a CVS, not to single them out, CVS, Dwayne Reed, whoever.
It's okay, we're getting sued after tonight's webinar anyway, so lawyers are on standby.
You walk into any one of the big box pharmacies, and what generally happens is someone comes up, the person gives you the prescription, and they ask, do you have any questions? the majority of people are going to go, no, I want to get the hell out of here. I've been online for 10 minutes.
Yeah.
And they leave.
And they don't know what questions
And
to
they
even
don't-
ask.
exactly right.
What is this thing? That's the first question.
Why did my doctor give it to me? What is it supposed to do?
Yeah.
And, do I really have to do it twice a day? When do I do it? How do I use it? When is it going to work? If I do it, do I use this when I'm sick? Do I use it all the time? I mean, it's very important.
All right, let's go to some audience questions. Russell, stick with us just in case people have questions for you as well. First question for Dr. Weintraub. If you eat heart healthy and exercise regularly at age 84, should you still take Lipitor if you have high cholesterol?
Very interesting question. The answer is, it's been shown that the answer is yes. Because if you don't take the Lipitor, the chances are the Lipitor is doing what needs to be done to absolutely lower your risk. There are people who would question whether that should be happening. I think one of the strongest risks for heart disease is age. You be the judge. Is a heart attack at 84 something you'd like to avoid? And the answer to me is yes.
Okay. Just to reiterate, and I have to ask this question because it's my mom calling in, what are the healthy numbers of HDL and LDL?
So LDL you would like ideally under 100, but no more than 130. And HDL tends to be gender specific because estrogen raises HDL. So in premenopausal women, an HDL over 50, in men over 40.
So women are protected initially.
Right. And that is probably the reason why they're protected. And when you look at the curves, they rapidly catch up to their male partners as they pass menopause.
So what percentage of your female patients after menopause go on hormone replacement?
Very few.
Very few. Okay.
And I'm telling, and there's a lot of animal, this is probably not the place for this, talk about getting sued. There's a lot of animal data that suggests that if you institute it early, not wait for them to become menopausal for 5 or 6 years, but do it early, that it may be absolutely fine. The only thing you got to worry about is from a cardiovascular perspective. But if you have a risk for uterine cancer or breast cancer, that's a whole other can of worms.
Gotcha. So here's a question. What is the difference between hypertension and venous hypertension?
Sure. So venous hypertension, they're probably referring to it in your legs. So the pressure in your veins and your legs can become high, and these are people who have dilated veins in their legs, maybe varicose veins, and they may find that their legs swell, particularly if they're on their feet a lot, or even more if they're sitting at a desk for hours at a time. So there's venous, and then so that's the hypertension I believe they're talking about.
Okay.
Arterial hypertension is what we discussed.
Okay, gotcha. What area do you measure your waist?
Right, essentially around your belly button.
Okay. Here's a question for Russell. Russell, and this is a question I have too. If I heard you right, and you did, Tom, if you have 25% capacity, how do you get along without oxygen? So Russell, do you ever wear oxygen?
When I fly, I have to have oxygen. Recent trip to the States, I was on oxygen for the flight. Day to day, no. I monitor my oxygen levels, and I'm consistently over 96%. There's times of different exercises I do where my oxygen levels have dropped, and they generally involve steep hills.
Russell, you had mentioned earlier today in one of our conversations, or maybe I read it, but you had mentioned that your lung damage was not due to smoking, but that you had a lot of scar tissue in your airways?
Yeah, that's right. The scans I've done have indicated that there's no damage from smoking. I wasn't a long-term heavy-duty smoker. I was more of a social smoker. I don't know whether that makes a difference, but it obviously has in my case. The doctors say that I've just, through my asthma and years of chest infections, bout of pneumonia, I've just had scar tissue build-up.
What do you think about that?
And I've got now.
So when you take your pulmonary ear and they do PFTs, do you respond to the bronchodilators? Do you have you don't?
So that's why they're calling them COPD, not asthma. And Russell, you show up, obviously, I mean, I'm asking questions that seem basic, but
you know what else I would tell you to do? This is my old pulmonary training, is that one of the things that plagues people, particularly in the airplane, is dry air. So one of the things you might want to try is a mucolytic, because there was a study done at one of the older, this is years ago, but then again, I'm an old guy, where they looked at COPDers and admissions or problems with recurrent infections. And people that took Mucinex, which is essentially, Robitussin, and in a pill version, had fewer respiratory infections. So that may be something you may want to consider on the way over, because in the airplane, the humidity is 0. And if there's anything that's going to happen there, like essentially the mucus can become like rubber cement inside the airways. And it can take days for that to happen. And there's somebody who might have a sinus infection. Before I get on the plane, I would take Mucinex. And I think it's something that you may want to consider, particularly as you get into the colder months. The humidity in the air drops.
Take it regularly, whether it feels
600 milligrams BID, it's over the counter.
That's a good idea.
You know, other things we're talking about with him, because we want to make sure he doesn't get sick on the way over. You know, masking in the air, in the airport, wiping down the seats. I just read an article where they say how often, and I'm using the term often loosely, is the airline required to actually clean the seats? And it's almost not at all, Russell. So we're talking about like really keeping him healthy, you know, on the plane and also when he gets here.
And hand washing when you're coming, if you're in the plane, you can be sure that somebody's a viral vector on that plane. They're going to be either a carrier or actually sick. So, you know, washing your hands when you go in and washing your hands when you go out.
Qantas, get at us. So anyway, I think that's all the questions we have. I want to just, if we could end on just a couple of things. I want to say thank you to Dr. Weintraub for coming out. If there's any more, Vladdy, we did answer your question. I want to thank you for coming out. Russell, I want to thank you for being here. We'll post links to the YouTubes for Dr. Weintraub, and Russell will post a link to your website and fundraising site. And anything else you want to just add to that?
I enjoyed it.
All right, thank you very much. Russell, any final parting words?
Looking forward to coming to New York.
All right, my friend.
luck,
All right,
Russell.
thank you, everybody. Thank you for tuning in, and have a great evening. See you next time. Okay, so we do have a tradition here at Pulmonary Wellness. You do know that I'm an artist, and so
Wow.
this is for you. I hope you're going to hang it in your office. Pulmonary Wellness approved.
No, it's really
Hey,
cool.
it's you.
That's, jeez, very nice. Mast cells, I love it. Endothelial
There you go.
Very
Good try.
cool.
Good try. And
Very
you're
cool.
one quickie up here.
Okay.
And just best rapper stance.
Dude.
Two Jews rap.